Hello, everyone, and thank you for sticking with us. We have a fantastic panel, so I promise you they will make it worthwhile. We are here to talk about future-proofing healthcare, and I think all of us can agree that healthcare right now is facing quite a few challenges. Drug prices are skyrocketing, there are inequities in access, huge gaps in the quality of care that people receive, and that's just routine healthcare. When it comes to a public health threat, whether it's natural, like we saw with COVID, or intentional with a potential bioterror attack, most countries, I think we'd all agree, are pretty unprepared to respond. Ken Chenault, who was on stage earlier today, spoke at a previous Time 100, and he said, complex problems like these, they don't have one solution. And no one person or one company or one group is going to have the answer. So that's why I'm thrilled to have our panelists here, because I think we're tackling these problems from very different levels. So Toyin, let's start with you. You created Cityblock Health, which is really kind of working from the grassroots up. Tell us what motivated you to create Cityblock Health, and what need did you see that needed to be fulfilled?
Awesome. Well, thank you so much. It's a real honor to be here. Like so many folks here, I have had firsthand experience trying to navigate the healthcare system. And we all know how fragmented, how complicated, how scary it can be. Even for those of us with resources, with education, with access, with great insurance. What is also true, no surprise, is that if you lack any of those things, if you are living in poverty, if English is not your first language, if you're struggling with multiple chronic conditions, if perhaps your challenge is a mental health challenge that folks tend to stigmatize, that all of these problems become even more complex. I'm a physician. I started my career in medicine in Boston, practicing in community health centers and safety net hospitals. And all I saw over and over and over again was people coming into the hospital with, in crisis, with medical, psychiatric, and social challenges that we put a Band-Aid over and sent them back out into the world for. And no surprise, in the data, what we see is that there are massive disparities in access and outcomes. We're seeing the same populations, people of color, immigrants to this country, people in poverty, people with disabilities and mental health challenges, having just unbelievably worse outcomes in the healthcare system, mortality gaps, morbidity gaps, real challenges that are frankly, I think, a real indictment on our system, given how many resources we have in this country. And so we built this business to try to address that, to prove that we can and should care for the folks who need it the most marginalized and vulnerable in our population better, that we can treat people with respect, with dignity, we can provide them access to high quality services, we can meet their needs on their own terms, and in so doing, we can change their outcomes and give them access to the best possible opportunities for health. And we can do this in a sustainable economic model, that there's a business to be built here because we waste so much money on the Band-Aid solutions that don't solve the real problems. And so that's what we've been doing, and that's sort of my motivation for doing this work.
I'm going to get back to that economic model because it's critical, to this whole idea of saying we can't just twiddle our thumbs, but we really need to have some concrete solutions. So I'm going to come back to that. But Luther, you are Executive Director of Patient Innovation and Engagement, and work directly with patients. And I'm sure you hear from a lot of them about drug pricing and why drug prices are so high. And clearly, as part of the development of drugs, there's research and development, which involves clinical trials, very expensive to test these drugs and profit. But it seems that if the whole R&D process can be streamlined, made more efficient, then the ultimate price that consumers see could also come down. What are some of the ways that we should be or are rethinking how to develop drugs, and particularly how to test them, to kind of bring that whole price structure down?
Great, well, thank you, and it's a pleasure to be a part of this panel. Well, I'm not a part of the commercial organization, but I am involved in our R&D, where our focus is on developing new therapies that improve and save lives. And one of the areas of focus is really bringing the voice of patients into the work that we do. So Merck, like other biopharmaceutical companies, really have recognized that incorporating the voice of patients into the work that we do is critically important, because these insights are really so valuable in terms of what they offer. And patients, as you mentioned, of course, are the beneficiaries of any new medicines or new medical interventions, so that involving them in those decisions, involving them, bringing their insights, their perspectives, what's important to them to our work is critically important, not only because we then take account of what's important to patients, but it helps us in developing therapies that are more, what I should say, patient-centered, patient-friendly research in our development. And a focus of the work that we're doing has really been around making this process of developing new therapies both representative and equitable, so that getting insights from the patients and the communities where the therapies will in fact be used. And this has been extremely valuable in terms of our efforts to overcome barriers to participation, many of which are well known, such as mistrust, understanding of what it takes to develop a new therapy, looking at the logistics, the lack of research sites in some of the underrepresented communities, but also just being asked to participate. So these are insights that are critically important to our decision making, both in terms of how we do business, but also making the work and the therapies better and more patient-friendly.
And potentially more efficient, right, the whole process?
And more efficiently, because when we speak about representative and equitable development of medicines, which we're not just talking about recruiting and enrolling patients in our research. And one of the lessons that we learned from the COVID-19 pandemic was not only that the spotlight that was shined on longstanding disparities, but that it was critically important to impact the communities in the development of the healthcare solutions, so that when you bring patients into this process, they not only contribute to advancing the science, but also to developing healthcare solutions that improve healthcare, that ultimately may advance equity. And there's also the confidence and trust in those therapies if patients in the communities where they're being used have been a part of the development program.
Now, Raj, you have a unique perspective because your career spans both working at the grassroots level for healthcare delivery, as well as most recently as special assistant to the president, seeing the perspective from the federal and national side. So let's start with COVID-19, because I think it's the thing now to kind of look at our experience in the pandemic, which was so unprecedented, and really see, are there lessons that we learned there? Because the vaccination program, for example, most people here have never seen anything like that in terms of a mass vaccination program, in terms of a shot being made available by the government. So what were some of the lessons, do you think, that we learned from COVID that we could, continue and keep in order to address issues of access, quality, and price even?
Well, thanks, Alice. And just to orient folks, I finished up at the White House in the fall of 2023, so I'm now a recovering public servant, as my therapist wife likes to tease me about. You may remember that the former president, President Trump, had disbanded an office at the National Security Council in the White House that was focused on pandemic preparedness. He did that in the year 2018. A couple years later, something called COVID happened, which I think folks will remember, and he was quite unprepared. There were statements being made, including that the disease will go away, it'll be a miracle. Yesterday marked the 4-year anniversary of President Trump saying that we should look at injecting bleach into people's veins to stop COVID. There's a reason a president could be unprepared when you disband such an office. So I say that to let you know that was the office then that President Biden restored, and I was eventually asked to lead. And we worked closely with the COVID team on this vaccination campaign. When President Biden came into office, his number one goal was to get shots in arms and to put cash in people's pockets who were out of work because of the the disruptions to business and the economy from COVID. There was a partnership between pharmaceutical companies, community pharmacies, community organizations, academic medical centers, doctors, nurses, community health workers. And there are 4 key shifts that I think are relevant for healthcare access today. The first shift was shifting from having staffing of healthcare from being doctors to being community nurses that are part of that team, and even community members, outreach workers that were part of the community and extended the medical team. The health care itself, the vaccinations, weren't delivered in hospital spaces or in clinics only. Many of you probably got your vaccines out at community sites or even in community pharmacies. So we shifted the space closer to the patient. The stuff of healthcare. You'll have to forgive me because my wife also doesn't like my habit of alliteration, but that's the only way I can remember things in medical school. So staff, space, the stuff of healthcare, the test, the treatments. We mailed those to people. We mailed tests to folks. We brought treatments into community pharmacies. And the systems, we decentralized healthcare by going more virtual, allowing telemedicine to happen in more places. That approach of high-tech, high-touch community healthcare really is not only key to ensuring vaccines get out to people, it helps ensure the missing half of healthcare is built in this country. Whether we're dealing with the maternal health crisis, we could have home visits happening to mothers that would help reduce maternal mortality. With naloxone and the opioid crisis, we have an over-the-counter medicine now that people who have overdose-affected neighbors can use. That's shifting all of the stuff of medicine closer to patients. So this approach of high-tech, high-touch community health care is important to build the missing half of healthcare. It's also a higher standard of care. And this mantra that got really emerged during the COVID pandemic, meet people where they are, was responsible for helping ensure that hundreds of millions of shots went into Americans' arms, 3 million deaths were averted, $1 trillion of economic losses were prevented, 13 billion of those shots got around the world. The United States supported many low and middle income countries to get that done. 20 million lives were saved. And you had the kinds of vision of healthcare where you had vaccines, people educating folks about vaccines in barbershops and in rickshaws in India, in the town square in Massachusetts, where I was involved in some of the vaccination outreach, and in the Himalayas of Nepal. But it was that shift to bring care to people, to meet people where they are. That mantra for the vaccination campaign, meet people where they are, should be the mantra for all of healthcare.
I think, Toyin, that's what you're doing, right? Yes, I think we all agree with that. With Cityblock, because meet people where they are, that worked with COVID because the government paid for the shots, because there were the government paid for like these mass vaccination campaigns, like you said. There was like some unusual and unprecedented things going on at that time. In the absence of that, Toyin, I wonder if you could address like how do we meet people where they are, and you're successfully doing that, and how do you change specifically the financial model, which right now means like when we've gone back now to the way that we do, traditional vaccination, we've seen vaccination rates go down. People don't get the shots they need, especially childhood vaccination. So tell us a little bit about how we take that mantra of, meet people where they are and make it work with the current system that we have.
Yeah, absolutely. I mean, I think there's a physical, a sort of temporal a component to that, which you really talked about, Raj, which is like you go out to see people, you meet them in their homes, you send the medications to their homes, you go away from, so historically medicine, certainly the medicine I was trained in, it's you come to me, you get what I can give you when I have time for you, and you're welcome, right? And that's kind of
And you have to pay for it.
And you have to pay for it. We take care of folks who receive their health insurance through Medicaid, so they typically don't pay cash out of pocket. But if you're, working 2-3 jobs and you've got 4 kids, your time is your currency. And so we ask people to take a day off work, that's cash out of your pocket. We ask them to pay for transportation, that's cash out of their pocket. We ask them to wait for us. And then we give them 10 minutes of something that typically doesn't feel like it's met their needs, and we say, you're welcome, go by. And so physically going to people is a complete transformation. I clinically fell in love with home visits very early in my career. Similar to Raj, did a lot of work overseas where this is the norm. But imagine the feeling as a clinician, or even in your role today in whatever job you have, if you just completely flip the paradigm, right? I'm going to someone's home, I'm knocking on their door. I have that little rush of adrenaline, I don't know what's inside. They let me in, they're sitting in their comfortable chair. I take off my shoes if that's the norm for them. They're in the clothes they wish to wear. I address them how they want to be addressed. You've completely flipped the dynamic, and the respect that you infuse in that relationship is really powerful. But the other component to meeting people where they are is actually much more, dare I say, spiritual, but there's a component to it that is about understanding where people are in their beliefs, their practices, their values, and earning their trust. Because part of what we have done and learned, I think, in healthcare is that if you just build it, they don't always come. Because if it makes them feel bad, if it does not feel respectful or dignifying, if we deliver care in a way that feels hierarchical, we miss the opportunity to meet people where they are. And we've been talking so much about how we address disparities in care outcomes. The first thing we have to do is earn back the trust that we've not earned from these populations, from the people whom we seek to serve. And that means saying, look, hey, I went to medical school, I believe that a vaccination, this vaccination that has been tested, that has been proven to be efficacious, is a good thing for you. But what do you believe? If you don't believe that to be true, then I need to meet you where you are. And we need to start to figure out how we build together a basis of information and knowledge over time. And it may take 5 visits. It may take 1. And so what we've been building at Cityblock is an ecosystem and a business model that allows us to take the time to physically go to meet people, to earn their trust over multiple encounters, and then when they are ready, to deliver the type of care that we know will help transform outcomes. And we can do this in a different business model. So most clinical practices get paid what we call fee for service, which means you come to see me, I write a prescription, I do a procedure, I counsel you, I bill the insurance, I get paid. Now, that prescription may not make you feel any better. In fact, you could feel worse, you could have side effects. You may not even fill the prescription. The advice I give you may not be the right advice. It doesn't actually matter, I still got paid. We don't think that's a good way to run a healthcare system. I would like my incentives to be tied to, do you feel better? Did you get the services that you need? Did we change your outcomes? Are we giving you more time in the community, in your home, with your family? Are you able to participate in society differently? And so we've built a business around a business model that allows us to be incentivized around those outcomes. So I can justify doing home visits, even though I could probably see 7 patients in the time it takes me to see 1. If that 1 home visit resulted in a transformational experience for a patient that allowed them to stay away from the hospital, allowed them to stay in the community, allowed them to achieve better outcomes. And we believe by doing that, we can build a sustainable business model that allows everyone, frankly, to have access to the type of care that we all deserve and would benefit from. But starting with the population that has the most to lose and the most to gain, frankly, from how broken our system is today, and focusing on the folks with the most complex needs and the most challenging needs to address and the biggest barriers to care today.
The buzzword, of course, yes, I think we all agree with that. The buzzword for that is value-based care.
That's right.
Right? And this is something that a lot of major health systems are also, trying to adopt, Kaiser being one of them. And what makes it work for them, though, is that they are the insurers as well for their members. So they're able to say, we have decided we're going to reimburse X for this, more for this, because it results in better outcomes. How are you working with the current system that isn't completely shifted to a value-based care model, but is still primarily fee-for-service? How are you making Cityblock Health work financially?
Yeah, so the reality is this system that I described, this sort of friction-full system that feels unsatisfying, is also incredibly expensive. It is way more expensive than it should be, and it is incredibly costly, particularly for folks at the furthest extreme of medical complexity. People who we care for have physical health challenges, mental health challenges, and social challenges. By definition, there are folks on Medicaid, so they live at or around the poverty line, and there are also people with lots of medical stuff going on and often psychiatric things going on. These folks tend to go to the hospital a lot as a usual source of care, because the reality is, with all that I just described, we've built a system where if I'm at home at 10 o'clock at night, the kids are finally gone to bed, I've been feeling unwell for 3, 4, 5 days. I haven't been able to take a day off work because I can't afford another day without pay. And I call my doctor's office. They will tell me, come in 3 weeks or 6 weeks. Make an appointment tomorrow. What am I going to do? I'm going to go to the emergency room. We've created a scenario where the emergency room is the only place where if I'm lonesome, cold, tired, hungry, or feeling unwell, that I can go reliably 24 hours a day and expect to be treated like a human and to be fully evaluated and maybe to have some of my material needs met. That is so inefficient and so costly. And so what we've done is we've partnered with health insurers to say, let's take the money we would have spent otherwise on all of this reactive Band-Aid slapping on problems, and let's invest it in community-based care. Let's invest it in building trust, engaging folks, providing them with high quality care in their homes on their own terms in a way that allows us to save money because they're not making that 10 o'clock at night visit to the emergency room for something we could have taken care of 4 weeks ago in their home on their own terms.
If I may add on, Alice, the kind of work Cityblock Health is doing should be scaled up, and I know Toyin's hard at work on it, and one of the things that in the White House that we try to create the right incentives around business models like this one was to try to get to work with the Centers for Medicare Services to enable them to pay community-based health workers, reimburse community health workers for the first times, which are central to models like Cityblock Health. These are folks who are hired, trained, equipped from their own community. Instead of talking to you about diabetes and high blood pressure at the exam table in a clinic like your doctor might do, they're coming to your home and talking to you about it and counting your pills at the coffee table in your living room. That kind of reform is critical to scaling this, and that needs to go along with the kind of work we need to keep moving forward. The Affordable Care Act has helped enroll 21 million Americans just in the last year, the lowest record number of uninsured rates ever we've under any president in history. And that, coupled with these kind of reforms, expanding the Medicaid program, which now 45 million Americans, including ACA, then Marketplace, those two together, about 45 million Americans depend on, and those are some of the folks who need health care the most but don't otherwise get it.
Mm-hmm. And I know that often when we talk about issues like value-based care and the kind of gaps in the healthcare system, it's at 30,000 feet. So I wonder if we could very quickly, we've got very little time left, just turn to one big issue that's been getting a lot of headlines lately, which is maternal mortality. And although it's declined since 2000, it's still not at the rate it needs to be to reach the Sustainable Development Goal of 70 deaths per 100,000 live births. We're quite far from that. And I think it will surprise a lot of people here that in the US, 33 mothers die for every 100,000 live births, even here in the United States. So Luther, I know Merck has been involved with addressing maternal mortality around the world. So tell us how we can apply some of these ideas about addressing inequity, about addressing access, and how your company is working to fill some of those gaps.
Well, thank you, Alice. That's actually a great way to end this session, so that and to look at what the cause of these deaths are in these young, healthy women. And I would say too that it's really terrific that there is such a spotlight on this issue now. Merck for Mothers, which is a global program that was developed by Merck in 2011, with the goal really of creating a world where no mother had to die while giving life. And our role in this has been focusing on the research that will understand maternal health and why these deaths are there and why there are disparities among different groups, but also the developing of actionable solutions. And currently, Merck for Mothers has about 60 programs in almost 50 countries around the globe. And the focus is really on prenatal care, postnatal care, but also that period of delivery around the mother. So making sure that you're listening to the people who are involved. As I was saying earlier, the women who are impacted in developing solutions that are not only actionable, but that will change and continue to improve this really quite deadly disorder.
Luther, Toyin, and Raj, thank you so much. I know we could continue talking about this, but our time is unfortunately up, and thank you for sharing your perspectives on how we can really make healthcare more impactful for everyone.
Thank you.